Yeah.
Please proceed your session.
Yeah. So, good afternoon, doctors. It's our absolute pleasure to welcome each one of you to this insightful webinar. We are honored to have such a distinguished gathering of medical professionals here today. Before we start today's session, allow me to introduce our company, Hetero Healthcare. Hetero Healthcare is determined to stay a step ahead to deliver superior and innovative care. Hetero Healthcare have established 300 products in the portfolio and are pioneering in quality and innovation. We've also launched 4 biosimilar products within the range of within last 5 years in the market, and also have a strong global presence in over 126 countries. The topic of today's webinar is Vonoprazan, the new age acid blocker, which we have launched first time in India. To shed the light, we are privileged to have Dr. Harshwardhan Dongre with us. Welcome, sir.
Thank you.
So Dr. Harshwardhan Dongre is a medical gastroenterologist practicing in
Okay.
Pune. Yes, sir.
Am I?
Yes, sir. You want to share something?
No, just carry on. Carry on.
Yeah. So Dr. Harshwardhan Dongre is a medical gastroenterologist practicing in Pune. He is an assistant professor in Bharati Vidyapeeth. So doctor will be sharing about the molecule and its advantages over PPI. So now I hand over the session to Dr. Harshwardhan Dongre. So you can start the session.
Thank you for inviting me for this webinar. The topic for today is acid-related disorders and is the role of vonoprazan in management as such. So for long period of time, for last 30-35 years, we have been using proton pump inhibitors on a widespread basis for tackling acid-based disorders, which include acid peptic disease, gastroesophageal reflux disease, functional dyspepsia, and so on. While PPIs have been useful very much, there are some limitations to conventional PPIs in in the in the light that they act on proton pumps which are only active. So inactive pumps remain still viable in the gastric mucosa. They do not completely inhibit gastric acid secretion, and around 20 to 50% of people of GRD might be resistant.
Sorry to interrupt, doctor.
Yes,
Can you switch on the camera?
just a moment, please. Just a moment. Hello.
Yes, sir.
Yeah, the light might be a bit off. Okay,
Yes.
is my screen visible?
The screen is visible, yeah. So light is
Just a
active.
moment. I'm just checking out. Is it better now?
Yeah, it's better,
Yeah.
sir. So be thoda
Okay.
bit louder also, sir.
Yeah. Okay. Fine.
Okay. Yeah. Thank you, sir.
Yeah. Uh, so as I said, even in terms of limitations to PPIs, is that they do not act on inactive pumps, and over a period of time, 20 to 50% of GID patients become resistant or partial responders to PPI therapy. They have a slower onset of action and require multiple dosing in a day within 24-hour periods, at least up to two. They are a bit unstable in acidic conditions, and hence some enteric coating might be required for optimum use. They do not provide stable separation of gastric acid. That is, we require pH to be above 4 to patients be turn to patients to turn unsymptomatic, but they PPIs may not do so all the time. And other concerns which have cropped up is the drug interaction, especially with clopidogrel. Most of the patients who require anti-secretory therapy are those a chunk of those are ischemic heart disease patients who are on clopidogrel, and PPIs will interfere with clopidogrel metabolism because of their interaction with cytochrome P40 system, and they have increased risk of bone fractures because they decrease the bone density, and hypomagnesemia is another adverse effect that has been flagged out in case of PPIs. So you can see from the chart the history of acid separation, where it started from lifestyle interventions which has been going on and will continue to do so. Then came the advent of antacids in terms of sodium bicarbonate, aluminum hydroxide, magnesium salts. Then came the H2 receptor antagonists, cimetidine, ranitidine, and so on. They worked well for a long period of time. Um, then came the proton pump inhibitors, the prazols, which continue to do so, especially for mucosal healing. And the new kids on the block are the potassium competitive acid blockers, that is the Prazans, and Vonoprazan, which has been approved for use as of now since April 2021. The PCAPs. They were developed in 1980s. They competitively and reversibly block the potassium binding site of the proton pump. And initial clinical development phases, they showed rapid onset of action, a larger accumulation in the gastric glands, and therefore a sustained effect was seen on the anti-secretory. The anti-secretory effect was sustained. They had a rapid onset and near maximum effect on the from the first dose itself. So these were the advantages were which in increased interest in the molecule, and uh, and such research was conducted. Uh, Vonoprazan is the first in class PCAB, which was developed by Takeda in Japan in February 2015, and subsequent clearances came from the Japanese societies regarding GARD, gastric use in gastric ulcer and duodenal ulcer, also in H. pylori eradication. In 2019, it was approved in China for management of gastric and duodenal ulcer and reflux esophagitis because of its mechanism of action in inhibiting the proton pump in a reversible manner. What is the mechanism of action of vonoprazan vis-a-vis the PPIs? As you can see from the chart, the PPIs are acting on the active proton pumps on the gastric parietal cell. They're inhibiting the proton pump, uh, but the inactive pumps remain viable. So when they come up to the surface of the parietal cell, there is no PPI available to inhibit their action, and hence the patient keeps on having recurrent symptoms. While in case of the Prazans, they suppress both the basal and stimulated gastric acid secretion at the secretory surface through inhibition of the proton pump in a potassium competitive manner. So they do not require acid production, acid activation as such by the gastric acid. So since this is the proton pump, and the Prazans are acting, getting bind to the active pump as well as the inactive pump. And the photodynamic effect on the pharmacodynamic effect of the Prazans has been seen demonstrated in this graph over a which shows its effect on the gastric pH over 24 hours. The time course of gastric pH indicates that the gastric pH tended to be higher after administration of vonoprazan in comparison with esomeprazole or rabeprazole. This difference was noticed within 2 hours of administration, and it continued till day 7. You can see this graph of mono versus esomeprazole and vonoprazan versus rabeprazole. This is the baseline acid pH, which is well below 3. This the second line shows on the day 1 effect of vonoprazan on the day 1, and this the third line shows the effect of vonoprazan on day 3, on day 7. So you can see on day 7 as well, the pH is maintained at around 7. Okay, while in esomeprazole, the pH is around 5 or 6 at day 7. Not so the case with the vonoprazan. Similar better efficacy is also seen in comparison with rabeprazole. So what are the dosage and indications of vonoprazan? Vonoprazan is currently being used for reflux esophagitis, gastric ulcers, duodenal ulcers, prevention of recurrence of gastric and duodenal ulcers in those who are having long-term NSAID use, and as an adjunct to H. pylori infection. The dosing ranges from 10 to 20 milligrams. In initial phases of reflux esophagitis, as an induction phase, we use 20 milligrams, and 10 milligrams is used in a on a maintenance dosage. The duration of therapy lasts for reflux esophagitis. The treatment is for 4 weeks, and another 4 weeks was the maintenance for maintenance. For gastric or duodenal ulcers per se, the baseline treatment induction is 6 to 8 weeks. After that, we do a check endoscopy and see whether the ulcer is healed or not, and the treatment can be discontinued. For H. pylori infection, we are widely using the kits for eradication of H. pylori, which in earlier currently which include a PPI as amoxicillin and clarithromycin. With now vonoprazan is also being used as which replaces the PPIs. There are also studies where we are using only vonoprazan and amoxicillin. The study I will quote later, display later, wherein we are completely doing away with the clarithromycin element, and the duration is around 10 days only. In special populations, we are going to put light on renal disease, liver disease, and pregnancy. In cases of patients with mm, in cases of patients with impaired renal function, the vonoprazan, if the eGFR is more than 30 ml, then the full dose can be used up to 20 milligrams. In less than 30 ml of GFR, the 10 milligram dose has to be used, especially in case of esophagitis. The maintenance dose is same, 10 milligram for 6 months. In cases where we have to treat for H. pylori, currently vonoprazan is not approved for those patients who have got H. pylori infection and have a GFR of less than 30. In cases of hepatic dysfunction, we classify hepatic disorders with use of the child score, class A, B, and C. For class A, we can use the full dose of 20. For class B or C, we have to use 10 milligrams per day. Importantly, vonoprazan is currently not being recommended for use of for patients who are pregnant and lactating mothers, because the safety studies are still not available. We require much more data to recommend use in this population. Another contraindication is obviously if the patient has experienced any hypersensitivity to vonoprazan, and those patients who are on rilpivirine. Rilpivirine is a drug which is forms a part of the antiretroviral therapy. So patients on of HIV/AIDS will not be prescribed vonoprazan. The adverse reactions which have come up upfront are from ranging in mild to moderate severity only, which the symptoms such as the patients may experience diarrhea, nasopharyngitis, abdominal pain, nausea, dyspepsia, and hypertension or headache, but they are mild and will get subsided with use. So how do PPIs fare with in front of vonoprazan? What is the comparative chart? In the action, PPIs require an activation to active form, that is the sulfonamide form, while vonoprazan do not require any, do not are not a pro drugs. They are directly active drugs. The concentration in the parietal cell is 1,000 times more than in the plasma in case of PPIs, whereas in vonoprazan, in comparison to plasma, the concentration in the parietal cell is 1 lakh times. The PPIs bind covalently with the proton pump, and vonoprazan binds competitively. It is a vonoprazan bind reversibly to the proton pumps, while it is irreversible binding to the proton pumps in case of PPIs. PPIs are short acting. They are meal dependent. The effect for PPIs takes 3 to 5 days to have their full effect, and while in vonoprazan, the full efficacy is demonstrable within the first dose itself. The pharmacodynamics state that PPIs are greater during the daytime, and vonoprazan the effect continues through 24 hours. The key benefits of vonoprazan hence are that the acid separation starts from the first dose itself. It is a rapid onset of action and in sustained action. They have minimal drug-to-drug interactions as of now, and they prevent nocturnal acid breakthrough. Nocturnal acid breakthrough is a very important symptom reported for patients who, especially those of GRD, because PPIs, the action wanes off about 12 to 16 hours later, and therefore in night times these patients may experience attacks of heartburn or regurgitation, and therefore vonoprazan, since they have around 24 hours action, they will prevent this nocturnal acid breakthrough. By definition, NAB or nocturnal acid breakthrough means that the pH is falling less than 4 for at least an hour. And importantly, vonoprazan can be consumed with or without food. Therefore, the timing with meals is not important in cases of the prazans. What are the clinical evidences? This was presented in the Japanese Society of Gastroenterology in 2021. Their practice guidelines, they have recommended for esophagitis the treatment dose as 20 milligram for 4 weeks and as maintenance therapy for 10 milligrams. Similar for all grades of esophagitis. In cases of peptic ulcer disease, it provides a long and potent inhibition of gastric secretion, and their forms currently has been included in Japan as a part of eradication therapy as well. it is also useful to heal peptic ulcers not only from H. pylori but also those formed as a side effect of NSAID use and low dose aspirin related ulcers. Acid inhibitory effect of vonoprazan, as I said, demonstrated in the earlier graph, uh, for day 7 and day 1 and day 7, in comparison with the PPIs, the acid anti-secretory effect of vonoprazan is much more than in comparison with the PPIs. This was a study published in the American Journal of Gastroenterology, where PCABs and PPIs were compared for grade C or D esophagitis. Only around, so in the initial treatment phase, the proportion of treatment failure was around 6% for PCABs, that is the persons, while for PPIs it was around 21%. And in the maintenance phase, again, PCABs fared much better than PPIs. These are the some of, as you can see from the chart, the molecules studied were vonoprazan, omeprazole, lansoprazole, uh, esomeprazole, keverprazan, and tegoprazan. Some of these molecules, apart from vonoprazan, is not available in India, but all those PPIs which are mentioned here are available and much in practice. This is a study which was published about use in H. pylori. You can see the efficacy with vonoprazan is much better and useful. It is actually non-inferior in comparison with PPIs. So we have an alternative in treatment of H. pylori. Another article which establishes the long-term safety and effectiveness of vonoprazan in preventing gastric and duodenal ulcers on patients of long-term NSAID use. They have found that the recurrence was less than 1% with vonoprazan. In summary, PPIs currently available are the mainstay for therapeutic management of acid-related disorders. However, the unmet needs which are come is the inadequate response to PPIs, their slower onset of action, and they do not prevent the nocturnal acid breakthrough. In this context, vonoprazan, which is also a proton pump inhibitor, uh, helps comes to the fore and is getting widespread acceptance. It was introduced for the first time in India uh, in the form of vonoprazan. It is effective from the first dose, and its potent action lends it a 24-hour effect throughout the day, and hence offers a better nocturnal acid breakthrough control. It has also been documented to have healing of the GERD and gastric ulcers in more than 90 to 95% in patients who have also been resistant to PPIs. Vonoprazan has helped in healing their ulcers, as which has been documented by endoscopy. It also increases the eradication rate to more than 80%, 88% in H. pylori for H. pylori eradication, and hence it is a safe and tolerated alternative. Only point being is still we do not have enough data for pregnant and lactating mothers, and therefore should be avoided in this subset of population. Thank you.
Participating doctors, if you have any question, you can type in your question in the message or chat box. It will directly go to Dr. Harshwardhan sir. If you have any question, just type in at the chat box.
I think there's a question about effect of vonoprazan on bowel movement. Vonoprazan has no effect on the motility. What we have seen with, if you see with PPIs, because they are with the use of PPIs, there is less of acid secretion is suppressed, and therefore there is a upgrading of gastrin secretion. Gastrin as a molecule per se has got pro-motility effect, and therefore long-term PPI use can result into diarrhea in some patients, but such effect has not been yet observed with vonoprazan.
Doctors, any other questions you have, you can type in. Okay. No questions, I guess.
Okay, yeah,
So thank you, sir, for this
thank
knowledgeable
you,
and insightful session, helping us understand Onoprozon in a better way, helping us
thank you,
understand PCAP. Thank you for your time as well. Thank
thank
you,
you,
doctors, for joining in.
thank you.
Thank you, sir. Yeah.